And next we have James Clyne, LeadingAge New York. Turn your speaker on.
Yep, thank you.
Yep.
I represent over 400 long-term care providers across New York State, the full continuum of care, nursing homes, assisted living, home care, managed long-term care plans, and housing for the elderly. Over the next 10 years, the over 65 and over 85 population in New York State is going to grow by 40%. Yet the state has completely failed to invest in services for seniors. Over 65% of the not-for-profit and county homes heading into the pandemic were already losing money. And 67% of the CHAs in New York State were losing money heading into COVID. The Medicaid reimbursement rate for nursing homes is the worst in the country when you compare expenses to reimbursement. There's a loss of $64 a day for serving Medicaid recipients in nursing homes. That's because the state has not provided a cost of living increase in 12 years, and at the same time has done $1 billion worth of budget cuts in long-term care over the last 3 budgets, twice the amount of any other area in Medicaid. At the same time, the state has failed to invest in long-term care services, either through the transition grant program or the Medicaid DSRIP program, the federal waiver. In the case of the transition program, only 10% of the funds have gone to long-term care. And as far as the DSRIP program, only 2% of the funds have gone to long-term care, even though long-term care makes up 42% of the state's Medicaid budget cap. Since 2014, 50 county and not-for-profit nursing homes have been sold, 13 have closed, and 30 assisted living programs have also closed. The system was fragile going into COVID. The state made the matter worse by doing a 0.5% Medicaid cut in April. So in the middle of the pandemic, the state did a cut to the largest funder of services in nursing homes and one of the largest funders in home care. The providers faced enormous costs, whether it was PPE, testing, or staffing. These costs have not been reimbursed. The federal government did provide some aid, and we thank them for that. But the federal aid covered for nursing homes covered roughly 1/3 of the increased cost as a result of COVID. So we had a fragile system hit by a pandemic that both the federal government, CDC, and the state was unprepared for. And the long-term care system has faced the consequences of that. Thank you for the opportunity, and I'd be happy to answer any questions.
Thank you very much. I see Senator Sue Serino's hand up.
Thank you, Madam Chair. And I would just like to start off by saying thank you to all of you for all of your great work and your great advocacy. And I know it's late, but I have a quick question for Jim. Jim, in your testimony, you mentioned that the medical model adult day healthcare programs have not been permitted to reopen since March of last year. And I think it's an important service for countless New Yorkers, not just for the program attendees, but also for the caregivers who get important respite using the programs, but it's often overlooked. So can you speak a bit, Jim, or anyone else who would like to weigh in to the impact of that policy and those closures?
Yeah, it's been a burden on the families who've had to take care of their loved ones at home. Often these are people with advanced medical conditions, which is why they are in the adult day health program. So you're completely on target. It's positive for the beneficiaries to be able to come somewhere, to be able to see other people, and it's important for the families to be able to take a break of providing 24-hour care. And we believe that we could open the programs, be safe, be effective, especially now with vaccine that's available. As a matter of fact, if they had included the adult day people in to the vaccination program with their parent nursing homes, they would all be vaccinated now, which is something we had advocated for, but we're not taking up on that.
That's a really good point too, Jim, because I was just going to mention that that would have been great, right, to have these medically fragile people vaccinated there. So,
Right.
Yeah, thank you. And hopefully, you know, we can all keep on, we've been advocating and we can all keep on advocating for them to reopen again. Thank you.
Helene, I think you have a couple of assembly members.
Assemblyman Jensen.
Thank you, Madam Chair. This question is for Jim. We certainly a lot of times today talked about needed increased staffing. So if you could just tell us a little bit about some of the struggles that your members face, whether they're nursing homes, assisted living, independent living, whatever it may be, some of the struggles that your members are seeing in hiring staff, recruiting staff, and not just nursing staff, but really, you know, activities, staffing, housekeepers, kitchen staff, things of that nature. Where are you really seeing the need, and what do they have to struggle with to get those people in the building and working?
Well, the staffing problem for my members is across the board, as you just pointed out, every job title you mentioned. Obviously, it's particularly tough recruiting RNs because we're competing with hospitals in many cases, which pay better. And you have to remember that the financial situation for my members was fragile to begin with, and then add the increased cost of PPE and testing on top of that. It's just been a struggle to recruit and retain staff, particularly again for the, I think the undeserved bad press about nursing homes. The workers who worked in the nursing homes through this pandemic are heroes, and they should be applauded just like the hospital workers were. And instead, you know, they're being made the scapegoat, which is really completely unfair.
So are you seeing of your members more nursing home related that have specialty units, whether they're pediatric units, respiratory units, are you seeing less of those being open or being retained because it's harder to get respiratory therapists or practitioners that can actually are well-versed in that practice area wanting to work in a long-term care setting as opposed to a hospital setting?
No, what happens is members struggle along, and if they have to, they end up, many cases, having to go to contracting out for services, which are more expensive. They like to hire, in many cases, hire their own staff, but sometimes you have to go and contract out. We always staff to be able to provide the services. The one place where there's a huge problem is in home care, where people upstate, they simply can't get, they're authorized for hours and they can't get caregivers to come in. And that's a huge problem upstate.
So is there a drop off then if you go to hiring from an agency or bringing in outside care staff? Is there a drop off in the level of care because they don't have an association with that specific facility?
I don't want to say there's a drop off in the level of care, but certainly there are some academic studies that show that the retention of staff in nursing homes is better for the long-term care because they simply know the residents better. They know what their conditions are. It's the same in home care too. If you can keep a consistent staff person in the home, it's better, regardless of the service.
Thank you, Jim. Thank you, Madam Chair.
Thank you. And
I
see that one more.
yes, we
Two more.
Over here, actually.
Oh,
Over here, actually.
right. Gustavo Rivera, Senator, Health
Yes.
Chair.
Thank you. I don't know how many folks are still tuned in, but I want to make sure that I give an opportunity to all of you, considering the folks you serve, everything that you point, and I don't need the 10 minutes. I will probably.
you only get 3. It's only
Exactly.
3 minutes
Don't
anyway.
Start murdering me
to
if I
talk-
take the 10
3
minutes.
minutes
No,
to talk
3
about
minutes.
the health
Thank you.
budget.
Yes, I know. I know. So I want to give you all opportunity, particularly considering the folks that you serve, all the issues that you mentioned around the populations that you care so much about. The question is an open question, and it is to all of you who would like to answer it. What difference would it make for the populations that you serve and the issues that you describe for the New York Health Act to become law? Anybody can take that.
We support universal coverage. Our concern is the state right now is the worst payer in the country for long-term care. So putting them in charge of paying for long-term care for everybody raises some concerns. So unless there's some protections to guarantee reimbursement, again, New York is the single worst payer in the country for expenses to reimbursement.
And weirdly enough, Mr. Clyne, thank you for bringing it up. There's actually language in the bill that specifically says that the rates to be just established by the board of the New York Health Act, the New York Health Act board would have to correspond to the cost of care, which is actually something that does not exist anywhere in law, anywhere else. So it would be in statute that the rates to be established would have to correspond to the cost of care. So there you go.
There you go.
Anybody else?
Okay.
Just want to make sure I give people the opportunity. Thank you, Madam Chair.
You. See, Helene, it was healthcare. It just wasn't the government.
That's great. That's great. We have two
Right.
two assembly members who will also be
Oh,
brief,
okay.
I'm sure. Assemblyman Kevin Byrne first.
Thank you. First, allow me to just agree with Heidi as far as asserting equal balance of power and having the legislature. I'm assuming that's what you're intending as a co-equal branch of government. I like that, even though I do have a slightly different take on the New York Health Act. I do want to make at least a statement for Jim, LeadingAge, and your members, and as well as a lot of the other folks that we're probably going to hear from later that represent adult care facilities, nursing homes. Now, we've heard a lot about this is a hot topic, and it really is sad that it's become this political issue. And I know a lot of us have been talking about this because we care deeply about the policies that we put forth as a state. And we want to make sure that we have sound policy that protects our residents, our fellow neighbors and New Yorkers. And we have, at least speaking for myself, a lot of frustration with the Department of Health and the governor's administration. But I don't want that to be turned to making certain industries and good people into scapegoats. We do have frontline workers in these adult care facilities, and I want to thank you for what your members have done. They should get a parade like every other healthcare worker, and I just wanted to make that statement, if nothing else. And as far as a question, Jim, to you, these 30-day amendments, I'm sure you can elaborate a little bit on some of your concerns. I think anytime we have these kinds of conversations about increased penalties, these are really, really significant penalties. This discussion should be separate from the budget. I don't think it's appropriate to include. And on adult care facilities, this removal of the rectification clause that's been brought forth, I have a lot of concerns about that. So Jim, I wanted to ask you if you had any other comments that you would like to elaborate with the rest of my time.
I just wanted to, that's a good point. The penalties are really over the top. And if you talk to anybody, nobody thinks that the health department is slack in their regulation. I just had a member call me today. They had their 9th infection control survey. No problems have been found, but their 9th survey since the start of the pandemic. I mean, it begins to get a little ridiculous. And on the adult care facility side, you have to look at those penalties. Those are per day penalties that they've enacted. So the penalties on nursing homes are different than the penalties on assisted living at adult care facilities. They're actually even more draconian than they look like at first blush. So the problem is not a problem of regulation. The problem is a problem of supporting providers in what they need with resources, with PPE, and with good advice on how to care for people.
Thank you, Jim. I appreciate your comments and your testimony, and thank you everybody else as well.
Thank you. Okay.
Thank you. Assemblyman Palmisano, right? You don't have, I don't see another senator.
Nope, I'm just looking for an assembly. Oh, there he is.
Yes.
Yes.
Oh, you're on mute.
Sorry about that. My question's for Mr. Clyne this evening. Mr. Clyne, I wanted to talk about the transition from long-term Medicaid managed care to the fee-for-service model, particularly for our nursing homes. It's my understanding from conversations that I've had that the fee-for-service model works better for some, while the Medicaid managed care model works better for others. And I'll give you an example. In my district, I had a facility that negotiated a fair rates and with a managed care company, which they thought were fair and proper, but now they were required to go transition to a fee-for-service model. And what that did is it's cost them $500,000 a year in reimbursements. And you couple that with the 1% reduction and other cuts, plus other pending actions that are being talked about with the legislature and the costs they had during the pandemic, it's really kind of a recipe for a devastating impact on a small rural facility and concerns it relative to other facilities in their long-term solvency. So my first question for you is, do you have any data showing how this has impacted your different facilities, your members, good, bad, or indifferent, the overall impact that's going to have on them?
The overall impact was positive to go away from managed care because of delays in payment. But there are rural facilities that are key providers in their area who were able to negotiate additional funds from managed care programs. And we would hope that the state would take that into account as they look at the rate setting system. If the state wants to keep not-for-profit and county providers in the system, they need to do something about the rates. If they don't, you're going to end up with a system that's going to be predominantly or almost exclusively for profit. I mean, it already is predominantly, but that's the way it's going.
Yeah, that's what I was going to get at. Wouldn't it have been better if they're going to move to that fee-for-service model, which if it works well for some, wouldn't it have been better and more advisable to have a hold harmless provision in that process, so those facilities that were able to negotiate better, fairer rates were not being penalized for being able to do that. And so, do you see any opportunity for that to be revisited? Have you had conversations with the State Department of Health or budget along this lines, looking at that as we move forward? Because I just think that would be a wiser thing to do instead of having those institutions out there like the one in my district is, again, lost $500,000 because of this change that they were required to go along with when they worked the process and had a fairer reimbursement.
Yeah, we have a couple members who are talking with the department right now, looking at the Vital Access program as a way to supplement their rate and maybe move to a transition. In rural areas, a lot of times it's the nursing home, which in many cases a vertically integrated provider, providing home care and housing. They're the only ones available to really do care management with boots on the ground.
All right, thanks. I'd love to have a future discussion with you on that issue. Thanks for what you're doing
Love to do that
for our communities. Thank you.